Okay, so now beginning the lecture over the cardiovascular system. So basically, the heart consists of 4 different chambers. Okay, and you have basically what we call the atria, which are very superior, and then the ventricles, which are going to be inferior. And the heart is divided onto 2 sides. Remember, anatomical position, it's the right or left of the patient. So this is going to be the right side of the heart, where this is going to be the left. What we're going to see is from the right side of the heart, we are going to carry blood to the pulmonary circuit. So blood's going to be going to and from the lungs. Why would blood go to and from the lungs? As it goes to the lungs, we're going to be dropping off CO2, and we're going to be picking up oxygen inside the lungs. So then we're going to bring back our oxygenated blood back to the left side of the heart. And the left side of the heart will then pump blood to the rest of the body, which we refer to as the systemic circuit. So the way that blood can go from organ or area of the body is through blood vessels. Arteries will always carry blood away from the heart. Typically, these will be oxygenated as well. There are 2 exceptions. Veins will always carry blood towards the heart. Typically, these are deoxygenated, although again there are 2 exceptions. And then capillaries are the thinnest walled vessels, which will actually allow for a gas exchange. We will talk more about blood vessels later in this lecture. Right now we're going to focus on the heart. Okay, so again you see here the heart's divided into our 2 different sides. Okay, so again this is going to be the right side of the heart. This is the left side of the heart of our patient. Okay, and the blue and the red are indicating how much oxygen is in the blood. So when you see blue, that means deoxygenated blood. That does not mean that the blood does not contain any oxygen. It's going to be less oxygen than oxygenated blood, which is indicated here by the red colors. Okay, so you see blood leaving the right side of the heart. Again, it's going to be entering the pulmonary circuit. So going towards the lungs, we're carrying deoxygenated blood. This is why it is blue, but you see arteries. Okay, so this is one of our exceptions. So pulmonary arteries, arteries carry blood away from the heart, where in the lungs, we will actually drop off CO2, which we will then breathe out. We are going to pick up oxygen. Okay, so then you see the blood leaving the lungs, entering the heart. These are veins. So again, this is one of your exceptions when the veins are going to be red. So they're carrying the oxygenated blood to the left side of the heart. So then it can carry it to the rest of the body, which is the systemic circuit, which of course is what we see here. So again, in most cases, arteries are going to be oxygenated blood to all the other tissues of the body. You see the color change here indicating capillaries, and then veins are blue. They should have deoxygenated blood going back towards the heart. So if we look at the heart specifically, the heart has some different layers over it. So it has, we call it pericardium. This is a double-walled connective tissue sac which surrounds the heart. This is a type of serous membrane, so we have talked about this previously. Okay, so we name the serous membrane specifically for the cavity that it's found in. So the parietal pericardium would line the pericardial cavity in which the heart sits. Okay, so this is the white that they have pulled away here. The visceral pericardium, remember visceral specifically refers to organ. So that's directly over the surface of the heart. It really does not appear like a layer that you can peel off. Okay, it's basically saran wrap that's directly on the surface. So you can call it visceral pericardium, or it also sits above the heart. So we also call it the epicardium. And the space here, that is where you would have pericardial fluid. And remember, the purpose of all serous fluid is to reduce friction. Okay, so we're going to reduce friction as the heart's going to expand and contract. Okay, so again, the heart consists of 4 different chambers. Draw kind of a rough picture here. Okay, so you have 2 atria. So this would be your right atrium. This would be the left atrium. And then the ventricles are the more inferior chambers. So you would have the right ventricle and the left ventricle. Then you have what we call major blood vessels. These are going to be bringing blood to or from the heart. Okay, so going to the right atrium, you're going to have the superior vena cava that's going to be bringing deoxygenated blood from structures above or superior to the heart. So that would include your head, neck, upper thorax, and your arms. And you have the inferior vena cava, okay, which is going to be draining blood from the rest of your body. So the lower thorax, abdominal, pelvic cavities, as well as the legs. Leaving the right ventricle, the great vessel you're going to have is called the pulmonary trunk. So this will be taking blood towards the lungs. So eventually that's going to split into the pulmonary arteries. Remember, pulmonary arteries, A away, A leaves. And then what brings oxygenated blood back towards are going to be your pulmonary veins back into the left atrium. From the left ventricle, we're going to carry blood to the rest of the body. That's what's going to be our aorta. Okay, so the pulmonary trunk leaves the right ventricle, is going to carry deoxygenated blood. The aorta leaves the left ventricle and carries oxygenated blood. Both of the vena cavae contain deoxygenated blood that enters the right atrium. Okay, so if we look at the heart again, if I zoom in a little bit, or just try to do a little thick in this one area. So the thickness of the heart itself, okay, is comprised of muscle, specifically cardiac muscle. So the cardiac muscle cells form the myocardium. Remember, we've talked about myo before. That refers to muscle, like we had the myofibrils when we were talking about skeletal muscle. So directly above the myocardium, again, epi means above, you would have the epicardium. It's going to be a very thin layer of connective tissue. Remember, we also refer to the epicardium as the visceral pericardium. And then lining the inside of the heart, it's actually going to be continuous with the structures that are going to form the valves as well. That's going to be the endocardium. Endo is inside, very thin layer of connective tissue. Okay, so talking about the chambers more specifically, okay, so if this is my heart, I have my right atrium and my left atrium. Okay, again, at least my right is going to receive blood from my superior vena cava and my inferior vena cava. Okay, so that's the right atrium. The left atrium is going to receive blood from, so the openings here, because they'd be coming on this side of the heart, from your pulmonary arteries. Okay, so these are very thin-walled vessels. Right atria receives again from the vena cava, left would be the pulmonary arteries. Underneath, again, the atria, you have the much thicker walled ventricles. So you would have the right ventricle and the left ventricle. And blood is kept separate between these two structures through valves. Okay, several different names we give for these valves. I like the term AV valve. AV stands for atrioventricular. So that explains exactly where these valves are located. So you would have the right atrioventricular valve as well as the left atrioventricular valve. The other names, respectively, for the right, we also call it the tricuspid valve. For the left AV valve, we would also refer to that as the bicuspid or mitral. And the purpose, again, is that they separate the blood from the atria and the ventricles. Then we have the chordae tendineae. These are going to be, layman's terms, we call these heartstrings. And basically, these attach to the AV valves, and they're going to prevent them from involuting as the pressure rises. So we'll talk about that later. What helps basically keep those heartstrings tight are these finger-like muscles that we find in the ventricles. And these are called papillary muscles. Also in the ventricles, you have textured muscle called trabeculae carneae. Carne is meat in Spanish. Trabeculae looks like shredded meat. Okay, so you need to understand the blood flow through the heart. So now we're going to look at how the blood flows through the heart. Okay, so the blood's going to enter your right atrium through the superior vena cava and the inferior vena cava. Okay, from the right atrium, it's then going to flow past the, and white here, this would be your tricuspid valve or right AV valve, into the right ventricle. From the right ventricle, we're going to pass another valve structure. This would be the pulmonary semilunar valve into the pulmonary trunk. Okay, and then we're going to split into your right and left pulmonary arteries. That would then take blood to the pulmonary circuit. So the arteries take it to the capillaries where we would drop off CO2, pick up oxygen, and now we're going to enter oxygenated blood back into the heart, into your left atrium, through your right and left pulmonary veins. Veins always return blood to the heart. After the left atrium, we have to pass the left AV valve, also called bicuspid or mitral valve, into your left ventricle. Now we're going to pass the last valve of the heart. This is your aortic semilunar valve into the aorta, okay, which will then take blood to the rest of the heart, into what we call the systemic circuit. Okay, so it doesn't hurt to review it, so let's look at this one more time. Okay, so again, you're going to have deoxygenated blood enters your body in the superior vena cava. It would be draining your brain, neck, upper thorax, and arms. Okay, you would also have deoxygenated blood coming from the lower body, lower extremities, including the legs, pelvic abdominal area, and lower thorax. Okay, so this deoxygenated blood enters your right atrium. Then it's going to pass the right AV valve or tricuspid valve, enter your right ventricle. Then it's going to pass the pulmonary semilunar valve, enter the pulmonary trunk, and then go into the right and left pulmonary arteries. Remember, arteries are always taking blood away from the heart. Pulmonary circuit, we drop off CO2, pick up oxygen. So now I have fresh oxygenated blood entering my left pulmonary arteries. You would also have from the right coming here. They're just behind these great vessels, so we can't see that right now. Into your left atrium, I'm then going to pass my bicuspid valve, also called the left AV valve or mitral valve, into my left ventricle. And then lastly, I'm going to pass, so back behind the pulmonary trunk here, this is your aorta, and you kind of see a small part of that white, the aortic semilunar valve, into the aorta, where then blood's going into the systemic circuit. Okay, so you have the papillary muscles, which are going to be holding down the chordae tendineae, the heartstrings, okay, which again are going to help the AV valves stay in place. So you have that on both sides of the heart. Then you see this other textured muscle. This is the trabeculae carnae, okay, that's inside the ventricles. Okay, so one thing that you should have noticed when you were looking at the heart, and I tried to draw it on my picture as well, is that the left side of the heart was thicker or more muscular than the right side. There's a reason for that, okay? Blood from the right side of the heart is going to enter your pulmonary circuit. The lungs are right next to the heart in the thoracic cavity. Blood from the left side of the heart enters your systemic circuit, which means the rest of the body. So it needs to be thicker because it needs to have a higher pressure in which blood is going to flow through the systemic circuit. So again, I pointed out the papillary muscles and the chordae tendineae that was attached to your atrioventricular valves, or the tricuspid and bicuspid valves. Again, the purpose is that when the ventricles are contracting, they are going to hold tight so blood does not go back into the atria. It doesn't backflow. Okay, we want it to increase the pressure, forcing the pulmonary and the aortic semilunar valves open. The semilunar valves prevent backflow into the ventricles after your ventricles have done contracting. So the valves help direct blood flow, make sure that it's one direction. Okay, so we talked about the general vessels, the large vessels that bring blood to and from the heart, but we need to talk about the vessels that supply the heart muscle itself, the myocardium. That's what we refer to as the coronary circulation. So you have arteries of the coronary circulation. These will have many branches, or what we call junctions. The technical term for that is an anastomosis. Anastomoses is plural. Why do we have so many routes for blood to flow? We want to ensure that the myocardium is always receiving blood. If the heart muscle itself does not receive blood and therefore oxygen, it's not going to be able to continue to contract and therefore apply blood to the rest of the body. So we see coronary artery disease. That is when we have blockage, partial or complete blockage of one of these coronary vessels. So I just drew a blood vessel representative here. And these green areas are representing these plaques. So plaques are buildups of cholesterol or calcium deposits that occur on the inside of a vessel, and they narrow it. Okay, so imagine if blood's flowing through here, it's going to have a harder time going through that narrowed area. Okay, so you're going to reduce the amount of blood that's going to be able to go to a certain area. So again, this is by a plaque, or a thrombus, which a thrombus is a blood clot that would be attached on the inside of a blood vessel wall. So when the heart does not receive, cardiac muscles do not receive proper oxygen, you have reduced blood supply. Reduced blood supply we refer to as coronary ischemia, and that can produce pain in the chest, a sharp pain. The pain is what we call angina pectoris. And if the heart continues to be deprived of oxygen, then it can result in a myocardial infarction, okay, which is a fancy word for a heart attack. Okay, so let's look at how cardiac muscle contracts. So first of all, when we look at the electrical current, cardiac muscle works like skeletal muscle. So let's review that really quickly. Okay, so you have these negative cells. We're looking at millivolts here. The cell at rest is negative. We're going to have sodium comes in. That's going to make it go more positive, which is what we call depolarization, followed by a repolarization. Okay, so we're looking at the basic action potential here. So you have depolarization, repolarization. So when you first excite the cardiac muscle, you're sending an electrical current. So we call that you are depolarizing the heart muscle. And what we're actually going to see is some of these cardiac muscle cells are specialized. They're what we call nodal cells, and they have the ability to induce their own action potential. So they're self-excitable. The other cells will just pass the current onto all the cardiac muscle cells that are around that cell. So gap junctions ensure that the contraction from these self-excitable cells spreads through the rest of the cardiac muscle cells. So these cells that are self-excitable, they make up a portion of the cardiac muscle inside called the intrinsic cardiac conduction system. So these cells, their job, some of them, is to set the rhythm and spread it to the rest of the heart. So they're going to excite or send these depolarization currents that will therefore make the cardiac muscle cell contract. This picture of the heart, the yellow specifically, is indicating where these specialized cells that will initiate and spread the contraction through the rest of the heart. Okay, so we're going to go ahead and go through this even though it's on the next slide. So you have this first portion, it's called the SA node. SA stands for sinoatrial. We commonly refer to this as the pacemaker because this is the initial cells that set the rhythm or the contraction waves of the heart. So the SA node will spread the depolarization through both of the atria. Again, it can spread easily because of those gap junctions. Okay, then the electrical current reaches the next portion of the intrinsic conduction system, which is what we refer to as the AV node, atrioventricular node. It is still in the very bottom portion, inferior portion of the right atrium. So it's going to slightly delay the electrical impulse and then spread the electrical impulse to the ventricles through the interventricular septum. So we have what we call the AV bundle and then the bundle branches, okay, which will carry the current towards this bottom portion of the heart, which we call the apex of the heart. And then it's going to spread up the sides of the ventricles through what we call the Purkinje fibers. Okay, so again, the depolarization current, which will cause contraction, spreads up the sides of the ventricles. Notice you also have some of the Purkinje fibers that are going inside the papillary muscles. Okay, because what's going to happen immediately after the depolarization of the ventricles, it's going to cause contraction. And when the ventricles contract, blood's going to want to move. We do not want blood moving back into the atria. So this is going to cause these heartstrings to remain tight so these valves stay closed. Okay, so blood will be forced to go through the aorta or pulmonary trunk. So the heart itself can control or set the rhythm of the heart. However, we do modify it using the extrinsic conduction system. And actually, without this extrinsic conduction system, we would probably have a resting heart rate of about 100 beats per minute. Most of us do not have that. because most of the time, the autonomic portion of the nervous system we are in is going to be the parasympathetic mode. Remember, parasympathetic is rest or digest, so you're not going to be exerting a lot of energy. So your heart rate is going to be low. So when the parasympathetic system is in play, you have nerve fibers that are extending from the brainstem, specifically the medulla oblongata of your brain, and these go to that SA node and they slow it down. They inhibit it. They slow it down to about 75 beats per minute. And the main nerve that does this, remember, nerves that leave the brain, we refer to those as cranial nerves. The 10th cranial nerve was the vagus nerve. That was the only cranial nerve that does not stay around the head or neck region. It goes into the thoracic cavity where it innervates the heart and the lungs, and it also, of course, goes to the abdominal cavity and pelvic. So when we want to slow down the heart rate, the parasympathetic mode sends messages that are going to slow down the SA node. When you want to speed up the heart rate, when you would be in sympathetic mode, so when you are in a E situation, so an emergency, if you feel embarrassed, if you're excited, or if you're exercising, we would want to increase the amount of blood that the heart's pumping. So we would want to increase the rate at which it pumps. Okay, so we would, in the medulla oblongata, we would basically stimulate the cardio-acceleratory center, which would increase the rate. It's also going to increase the contraction of the cardiac muscle. So the heart muscle itself is actually going to contract harder. That's going to be called what we call force of contraction. So not only are we increasing the rate at which the heart's contracting, we're increasing how hard it's actually contracting, therefore increasing the amount of blood that's going to be leaving the heart. We also are going to increase the amount of blood that's going to be going to the heart muscle itself. So we have an increased amount of blood that's entering the coronary arteries. Okay, so here we can see the portions of the intrinsic system and how that responds to what we call the electrocardiogram, or for short, ECG or EKG. So this is a recording of the electrical events. So basically where depolarization. Okay, so when the inside of the cell becomes more positive because sodium is entering it. Okay, so again, what we see, you initiate it at the SA node. Okay, so when the SA node starts the depolarization, that begins what we're going to call the P wave. Okay, so the P wave is the depolarization spreading through the atria. Okay, now we see a delay at the AV node. Why do we have a delay? So again, the depolarization is going to cause contraction. Well, the contraction of the atria is going to fill the ventricles with blood. So we want to make sure that the ventricles have time to adequately fill with blood after atrial contraction before we try to make the ventricles contract. So that's why we have that delay. Then you start to see the impulse being spread down the ventricles through the interventricular septum and up the sides. So again, that's going to be the AV bundle branches, and the Purkinje fibers. So that creates, we see it moving through what we call the QRS portion of our, remember we're looking at the EKG or ECG. This is the electrical event that's occurring through the heart. And then we're not showing this portion on the actual picture, but the last portion is going to be the T wave. And that's going to be when the ventricles are in repolarization, or when they are relaxing. Now you might notice we did not see a specific wave when the atria were relaxing or in repolarization. That is during the QRS. So while the ventricles are in depolarization, the atria are in repolarization, and it's being masked or covered up. Okay, so now we're going to talk about the cardiac cycle. The cardiac cycle is the amount of time between when you start one heartbeat and the beginning of the next. So during a cardiac cycle, each heart chamber, so both the atria will contract, then relax, and again, as the atria are relaxing, the ventricles will contract and then relax. And the purpose of this is the contraction is going to increase the amount of pressure on the blood, on the fluid inside the heart. And the increase of pressure is what forces blood to move. So just like we were talking about passive transport processes, things want to move from high concentration to low concentration. Pressure is going to naturally move from high pressure to lower pressure. So we need to be able to change the pressure relationship by making a chamber contract, and that will keep blood flowing. So parts of the cardiac cycle, we have systole and diastole. Systole is when a chamber is going to be contracting. So during atrial systole, the atria are contracting, so you have increased the amount of pressure, therefore forcing blood to leave the atria and enter the ventricles. When the ventricles are contracting or are in systole, at first, blood does not move anywhere. Okay, so when the ventricles initially begin to contract, that's going to force your right and left AV valve or tricuspid and bicuspid valve closed. Your semilunar valve, both the pulmonary and aortic, were already closed. So blood's not moving anywhere. You've increased pressure. That increased pressure then forces the pulmonary semilunar valve and the aortic semilunar valve open. So blood's going to be entering your pulmonary circuit through the pulmonary trunk and the systemic circuit through the aorta. Now the ventricles need to relax. So the ventricles will go through diastole. So when the ventricles are relaxed, all of the heart valves will be closed. Blood is still returning to the atria from the vena cava and from the pulmonary arteries. So as blood continues to fill those chambers, you've increased the pressure, and eventually that will force your right and left AV valve back open. And then the atria will contract again. Now, of course, what's missing here is atrial diastole. So as soon as after the atria go through systole or contract, they're going to go through diastole. And again, when the atria are going through diastole, the ventricles will be contracting or going through systole. So a doctor can listen to your heart and make sure everything sounds okay by using a stethoscope. Okay, so they have the earbuds, which of course go in the ears, and then the diaphragm is the round portion that they will actually press on the anterior and sometimes posterior portions of your chest. And so the sounds they're hearing are what we call auscultations. There are really 4 sounds. We're only going to talk about the 2 main ones that they're listening for. They're making sure that the blood is flowing the correct way, so they want to hear at least 2 very distinct sounds that ensures the valves are closing. If valves are closing properly, then blood flow will be directed in the appropriate direction. If you hear what we call heart murmurs, any abnormal sound, gurgling, you don't hear the sharp sounds, then it possibly could indicate that valves are not closing all of the way. Okay, so first I'm going to talk about the 4 different placements of the diaphragm, the round portion of the stethoscope that they have. So you can use the mnemonic device, all physicians take money. Okay, so if you actually look in the center portion of the chest here, those dots are indicating where the valves of the heart are located. So they're very close together. So we basically move the diaphragm, the stethoscope slightly to the side so we can get a better sound for each valve. So the red, when you place the diaphragm in that placement, you're listening to the aortic semilunar valve. The green area would be listening to the pulmonary semilunar valve. The blue area would be tricuspid, also called the right AV valve. And the purple area would be when you're listening for the left AV valve, bicuspid, also called M here for mitral. And again, that's all physicians take money. Here, we're looking at this graph, we're looking at a few different things. So first of all, on the side axis here, you have pressure. And we measure the amount of pressure in blood as millimeters of mercury. So that's the mmHg that you see there. And this is time, okay, in milliseconds, that's going off the bottom axis here, even though they don't have that labeled. So we're just going to be looking at one side of the heart. Specifically, we're looking at the left side here. So what we see, this also we can see it going with the EKG as well. So this small increase in pressure right here, that is when the left atrium is contracting. Okay, notice immediately when the left atrium stops, your ventricle is going to begin contracting. As soon as the ventricle starts to contract, that's going to force that left AV valve closed. Keep in mind, whatever's going on the left side is also occurring on the right side as well. So we're preventing blood from backflowing back into the atria. Okay, but during this period of time that we have between this dot and this one, blood is not moving anywhere. Okay, so blood is stuck inside the ventricles because both the valves are closed. Okay, so that's why you see a dramatic increase of pressure. So the ventricle's squeezing, blood cannot move anywhere. Eventually, when you hit this point, the pressure inside the ventricles is now going to be greater than the pressure inside the aorta. So the semilunar valve is open. You have blood actually leaving the heart, entering the aorta, therefore the systemic circulation here. And as blood leaves, of course, the pressure is going to start to drop. And then at this point, the pressure inside the ventricles is now less than the pressure in the aorta, so that's when that aortic semilunar valve is going to close again. Okay, we still have not, the AV valves, notice, are still closed, so we have a drop in pressure, okay, because we're actually not really making your ventricles contract anymore. However, the heart is still filling up with blood. So as the atria are filling up with blood, that's going to force those AV valves open at this point here. And then you'll do it all again. So the sounds we're going to be focusing on is what we call the S1 and the S2, or the lub-dub. Okay, so this is when you're listening to someone's heartbeat. It's the lub-dub. Lub-dub. So the lub is the sounds of the blood hitting the AV valves as they close. Remember, blood is not allowed to move anywhere. The dup sound is when the semilunar valves close. Blood is going to hit those trying to backflow into the heart. So those are the main two sounds that you need to know, and the most dramatic that you can actually hear just when you put your ear to someone's chest. Okay, so we need to talk about how much, the purpose of talking about the heart is because the heart is an effective pump to make sure that blood's going to move through the rest of the body. So we need to see how much blood can the heart pump. We call that amount of blood that the heart can pump, each ventricle in 1 minute, is called the cardiac output. So when you see CO, it's cardiac output for short. So again, that's the amount of blood. We measure amount of blood here in milliliters per minute. Okay, so we calculate cardiac output. We're going to take the heart rate, or how many times the heart is beating per minute, and we're going to multiply that by the stroke volume. And I actually want to show this in a different way. So the way that it really is, beats per minute, okay, is the heart rate. Stroke volume is the amount of blood that's going to be pumped out of each ventricle within each beat. So what affects that, we talked about that, that was force of contraction. So the stronger the force of contraction, the larger the stroke volume. So what you have here, the beats are going to cancel out, and what you're left is the volume of blood, or milliliters over a minute, which of course is what the cardiac output is measuring. So basically what we see is to increase the amount of blood that the heart can pump to the rest of the body. You can do that by increasing just the heart rate or just the stroke volume, or you could increase both, which would significantly, increase the cardiac output. So 2 ways in which the body can vary the amount of blood that the rest of the body is receiving. Okay, so here we're basically looking at primarily the normal values that we see here. So we're assuming that the heart rate is going to be the normal 75 beats per minute. Okay, and we're going to give the person a stroke volume of 80 milliliters per beat. So again, we're saying every time the ventricle contracts, 80 milliliters of blood is actually being ejected. Okay, so we're just going to multiply the two together. So 75 times 80 is 6,000 milliliters per minute. And of course, there are 1,000 milliliters in 1 liter. So you could also say that's 6 liters per minute. But remember, the average person has between 5 liters and 6 liters, depending on the size. Smaller women are typically going to be closer to the 5 liters. Men are going to be closer to the 6 liters. So we would want to adjust the amount of blood the body's giving when the demands of the body increase. When you're working out or when you're stressed, we would need to increase the cardiac output. Okay, so we could increase that again by changing the heart rate and or stroke volume. So we can increase heart rate up to a total of 250%. Stroke volume can be increased up to an additional 200%. And of course, these values are in a very healthy individual that exercises on a normal basis. A normal person that's not used to exercising, wouldn't want to increase your heart rate by 250%. You would want to work up to that. This is basically why crazy healthy athletes can have such a low resting heart rate. Okay, they can have a heart rate as low as 50 beats per minute, some even lower, because the stroke volume is so greatly increased. Their heart is very strong, so every time the ventricle actually contracts, more blood is being ejected. Therefore, they don't have to make it beat as often. Okay, so how do we alter the heart rate? Kind of talked about this before. It's through the autonomic nervous system. Neural controls that are through the hypothalamus and the brainstem, specifically through the heart, typically through the medulla oblongata. So during sympathetic response, again, that would be in an E situation, an emergency, you're excited, you want to exercise, or you're embarrassed, you would want to increase the amount of blood that would be going to the body. So we would do that by increasing the neurotransmitter norepinephrine and epinephrine. That would cause an increase in heart rate and an increase in stroke volume. Both, of course, would increase cardiac output. Okay, if we want to decrease the amount of blood that's going to the body, we could do that by simply decreasing the heart rate, and that's what parasympathetic does. So that's a difference that you see. Sympathetic fibers actually go directly to the heart muscle. So when you're in stimulation, you can make it contract more, but you're not going to inhibit any more so. So we're really just going to decrease how often we're going to be contracting when the neurotransmitter acetylcholine, and really that should be a capital C, is released. So we decrease cardiac output here by decreasing the heart rate. So now the other part of the cardiovascular system, blood vessels. So how do we take blood to and from the heart? So arteries, again, A, away. Arteries carry blood away from the heart. And again, they will always contain oxygenated blood, therefore appear red in a model. 2 exceptions. So pulmonary arteries are taking blood away from the heart toward the lungs. So these would be deoxygenated blood. And then in the umbilical vessels, that are leaving the fetus, re-entering the placenta of the mother. That would be your umbilical artery. That's going to be deoxygenated as well. Veins will always carry blood toward the heart. Again, you have the two same exceptions. So pulmonary veins will be oxygenated because they're bringing blood back towards the heart. Umbilical veins carry oxygenated and nutrient-rich blood away from mom's placenta towards the baby. Most of the time, again, veins would be deoxygenated. Arteries and veins are pretty thick-walled, so thick that blood can't actually leave those vessels. So you must have the microscopic capillaries, which actually allow for oxygen and nutrients to leave the blood and metabolic waste to be picked back up. Okay, so that's what we see in this system here. So again, the heart's the pump that increases the pressure, and this pressure is going to keep blood moving away from the heart down the arteries. So basically you see the arteries start large. As we make our way towards the tissues, they get smaller and smaller. Okay, capillaries, we're going to be dropping off oxygen and nutrients, picking up metabolic waste on the venous side. And then veins are going to drain all of our tissues, of course, and take it back towards the heart. We also see another organ system here as well, which we're actually going to talk about it next. That is the lymphatic system. So there will be some fluid, okay, that's going to remain in our interstitial spaces, or the extracellular fluid, and that will need to be picked back up by the lymphatic system, which eventually dumps blood back into the venous system as well. Okay, so just a few key differences between arteries and veins. So arteries are going to have thicker walls. The reason is because they have a higher blood pressure. That's what BP is. They have a higher blood pressure because they're closer to the heart. So they have to be more resilient to accommodate this pressure. They're actually going to have more smooth muscle, which makes up the middle layer of a vessel wall, as well as more elastic fibers, which have the recoiling ability. Veins will be thinner walled. Veins are also going to have a much larger lumen. So the larger the lumen, or the opening, so the larger the lumen, the less the blood pressure. So veins have a large lumen to lower blood pressure because, again, we want pressure to move from high to low. We want to make sure that blood returns back to the heart. So the vessels, which will constantly change in diameter based on the needs of the body. Okay, so if you want to increase or decrease the amount of blood going to a particular tissue, or if you need to decrease or increase the amount of blood pressure, that would be when the vessels, these arteries, would change in diameter. So if you decrease the size of the lumen, if it gets smaller, we call that vasoconstriction. That's going to cause an increase in blood pressure. If you increase the size of the lumen, we refer to that as vasodilation. That's going to decrease the blood pressure. And the vessels which typically do this are the smallest of the arteries, which we actually call arterioles. So they are the main vessels which will constrict or dilate, again, therefore controlling blood flow to specific tissues and helping regulate blood pressure. So again, capillaries are microscopic. They're only going to contain the very innermost layer of the blood vessel wall, which we call the tunica intima, which is going to be made of your epithelial tissue. And all blood vessels, the epithelial tissue they'll have is simple squamous. So it's very, very thin. They do have pericytes that surround them that basically make sure that the vessel wall stays open and doesn't collapse because it's so thin. The smallest of the capillaries will only allow one red blood cell to pass at a time, so their diameter is incredibly small. And remember that most tissues in our body are vascular, except for cartilage, epithelial, and then there are two places of the eye that do not contain capillaries as well. So we have billions and billions of these capillary beds all over the body. So they allow for oxygen to leave the capillary and enter the tissue, They're going to pick up the waste gas CO2. They're going to drop off nutrients and pick up metabolic waste as well. Of course, we can also have hormones or other blood-bound substances that can also use the bloodstream or the lymphatic stream to get to where they need to go. So capillary beds are internetworks of vessels between, again, the smallest of the arteries we call arterioles, the smallest of the veins we call venules. And a true capillary bed is actually about 10 to 100 of these little vessels between them. So I'm actually just going to show a picture here. Okay, so a true capillary bed has several of these little exchange vessels. So if you want a tissue to be receiving a lot of blood, then you want all of the true capillary beds to be open. Okay, so what you make happen, these pre-capillary sphincters, which are little bands of smooth muscle, we're going to make those relax. That's what allows blood to fill up all of these other areas and therefore supply that tissue adequately with blood. If you do not need a lot of blood at that tissue, then you're going to cause the pre-capillary sphincters to contract, which would stop blood flow through these other exchange vessels and force blood to go through what we call the vascular shunt, which is where it goes straight from the arterial side into the venous side. So the tissue is still receiving blood, but over long periods of time, that's not going to be adequate. And so if we're looking at when it would do this, let's say, for example, parasympathetic mode, rest and digest, this is what your digestive organs would look like. They would be receiving adequate amount of blood. So would the urinary organs as well. This would be more what your skeletal muscles would look like. Okay, they would have restricted blood flow. Obviously, if you switch it, let's say something scares you, so you go into sympathetic mode. Now, the skeletal muscles will need to receive more blood, so they will look like this. You'll have to decrease the amount of blood going to other parts of the body, like the digestive organs. Okay, so the capillary beds in a particular organ can go back and forth, again, based on the demands of the body at that time. So venules are small veins. So when venules converge, we call that a vein. So they're going to collect all of the waste-filled blood from the tissues and the organs, and they're going to return it to the heart. Veins can actually hold a lot more blood than arteries because of their very large lumens. Therefore, we call them capitance vessels. They typically contain about 55% of the blood of the body, but they can contain up to 65%. Again, we kind of talked about this earlier. They're going to have thinner walls because they do not need to withstand such great pressure. They also have larger lumens, again, to actually, because the pressure is so low, we want to increase blood flow. So by increasing the lumen size or decreasing the resistance, blood can flow much easier. Blood pressure is going to be lower in the arteries because it's further away from the heart. And the middle layer and the external layer will still have the collagen and elastic fibers, allowing for the stretching of that vessel wall. Blood flow refers to the amount of blood or volume of blood that can go through a vessel and organ, or you can talk about the entire circulation in any given period of time. So we measure that, again, milliliters and the amount of minutes. So that's the same measurement that we use for cardiac output. Okay, so if you can control how much blood leaves the heart, again, you're basically controlling how much blood is flowing through the rest of the circulatory system. When we're at rest or in parasympathetic mode, it's relatively constant. It doesn't need to change. However, when our activities change or different demands of the body increase, we would need to increase the amount of blood flow through that particular area. So we can see how much blood flow is going to go based on blood pressure. Again, things naturally want to move from a high pressure to a low pressure. So blood pressure is the amount of force per unit area on the wall of a vessel or on the walls of the heart. And we express it in millimeters of mercury. And typically when you're just talking about blood pressure, you're assuming we're talking about the arteries, the largest of the arteries closest to the heart. We can talk about blood pressures of capillaries and veins, but at this point in 2404, we do not get that detailed. Okay, if you take ANP2, we definitely talk about those different pressures as well. Okay, so again, we're going to assume when you hear blood pressure that we're talking about those in the arteries. Okay, so we have to have a pressure gradient. That's a difference. You have to have a high pressure and a low pressure because, again, that gradient is going to keep blood moving. So most of the time when you go to the doctor, they give you your blood pressure. It's a number over another. This would be the average for a healthy adult male. That top number, the 120 millimeters of mercury, that's going to be when your ventricles are in contraction or in systole. So that's your systolic blood pressure. The 80 millimeters of mercury is going to be the pressure that's being exerted by the fluid when the ventricles are in diastole or relaxed. So anytime you decrease the lumen size, okay, cause vasoconstriction, you're going to increase the amount of blood pressure. If you increase the lumen size, which is what we call vasodilation, that's going to allow the blood pressure to decrease. And again, by having vasoconstriction and vasodilation, we can direct blood flow to particular organs.